Assalamu alaikum warahmatullahi wabarakatuh. Good morning, dear colleagues and friends. Welcome back to our sessions to discuss one of the topics from all the points. We are going to discuss this topic from the part 3 exam point of view. We will give some more details in case any of the candidates who are going for a clinical exam in part 2, MRCOG or any other exam, he will have a full idea about the topic. And we'll discuss it from the clinical point of view because this diagnosis is usually missed or overlooked in the clinic for patients who are complaining of chronic genital pain. So our task today is about the chronic genital pain or female genital pain, and we are going to discuss in specific the diagnosis and management of vulvodynia. So this task, when it appeared as a structured discussion task. It is a repeated task in the previous exams for the part 3, and it appears in the single best answer of part 2 also. So when it appeared in part 3, it appeared as a structured discussion to evaluate the candidate in the information gathering, the communication with colleagues, patient safety, and applied clinical knowledge. The candidate here will be acting the role of ST5 in the clinic. He's going to see a 30-year-old lady transferred from the GP complaining of chronic vulval pain. The consultant here or the examiner, he is going to discuss the management of this case with the candidate in the exam. During the 10 minutes, the candidate is expected to explain what is the possible differential diagnosis in the case and what are the additional clinical details that he need to know to confirm or to exclude the condition, and to provide a logic management plan, and if there are any prompting questions from the examiner to be answered. There was discrepancy between the candidates if there was a GP letter or no, but I formulated the task here to include a GP letter where the patient is transferred. She's 30 years old, nulliparous, complaining of chronic pelvic pain. The patient is having a history of vulval burning pain affecting her daily activities and sexual function, so it's affecting the quality of life and the duration. Either mentioned or not mentioned, chronic or persistent pelvic pain means at least 3 months. So here in the scenario, it is for 6 months duration. The genital examination is normal, and all the swabs collected by the GP were negative. She's otherwise healthy, normal body mass index, no significant medical or surgical history, and they are requesting you to see the patient and to assess her condition regarding the chronic pelvic pain and to give an advice regarding the further management and further specialist intervention. So this is the task that will be seen by the candidate. Now, we should have a plan. So the plan here is to explain what is the possible differential diagnosis, what are the additional information that we need to know to confirm or exclude the differential diagnosis, and once we will reach the diagnosis of vulvodynia, what will be the management of vulvodynia. So this is the plan, this is your agenda when you are in front of the booth in the 2 minutes preparation time. So let's start by the differential diagnosis here of this case. So what's the differential diagnosis of chronic genital pain or chronic vulval pain? We have to understand that the term chronic here means it is a vulval pain and persisting for 3 months or more. So this is the definition of chronic vulval pain. The vulval pain or chronic vulval pain is classified into two main general diagnoses, which is vulval pain caused by specific disorder and vulvodynia. So these are the two headlines, either vulval pain with a definite cause or with a specific disorder, or vulvodynia. The vulval pain caused by specific disorder, it may be due to different types of infection, mainly recurrent candidiasis, bacterial vaginosis, or herpes simplex. It may be due to inflammatory condition like lichen sclerosis, lichen planus, or autoimmune disease. It may be due to neoplastic disorder, and this is the most important red flag that you have to take care that will need further investigation, like in Paget's disease, VIN, and vulval carcinoma. It may be due to neurological disorder like in pudendal neuralgia, nerve compression or injury, and in Fowler syndrome that we have discussed as a new recall also. The trauma in female genital mutilation after childbirth injury, in case of pelvic floor descent or post-traumatic nerve injury, It may be due to iatrogenic, like in post-surgical nerve injury due to compression or malposition, chemotherapy or radiation. It may be due to hormonal deficiency, like in cases of menopause, genital atrophy, and in lactational amenorrhea. It may be due to contact or allergic reactions to some soaps or creams or sexual products, and it may be a referred pain from the urinary tract, from the gastrointestinal tract, from other conditions like bladder pain syndrome or irritable bowel syndrome or sacral nerve pathology. So this is the first part. When the examiner is asking you, what's your differential diagnosis? You will say vulval pain may be caused by specific disorder, and you will start explaining what are the specific disorders that may cause a vulval pain. The other category is vulvodynia. Vulvodynia, here the chronic vulval pain is 3 or more months without any clear cause, but it is often associated with other conditions. So here is an association in the vulval pain which is caused by specific disorder. This is a causation. So the cause of the pain here may be the infection or the neoplastic or the neurological, whatever the condition here, it is the cause. But in vulvodynia, it is a pain without a clear cause, but there are associations. The associations, for example, include other chronic pelvic pain. Vulvodynia may be associated with other chronic pelvic pain, but it's not the cause, like as we mentioned, bladder pain syndrome, fibromyalgia, IBS, temporomandibular joint or orofacial pain. It may be due to it may be associated, not due to, associated with other genetic condition like polymorphism, may be associated with hormonal factors like drug-induced changes or low levels of hormones, inflammation, local tissue inflammation, musculoskeletal issues like overactivity of the pelvic floor muscle. It may be associated with a neurological condition, either central or peripheral neurological condition, and psychological factors. A very important factor to be explained, that the psychological factors like the mood, the stress, sexual dysfunction, abuse, especially if there is a past history of a child's sexual exploitation, this may be an association with vulvodynia, and it may be due to a structural defect like in pelvic organ prolapse and perineal descent. So the key differences between the two conditions that may cause a chronic pelvic pain is that in a specific disorder pain, we can find as a cause like infection, trauma, or disease, but in vulvodynia, it is a long-term pain. There is no identifiable cause, and it is not influenced by it may be influenced by biological, neurological, and psychological factors, which is a very important point to be discussed. So this is a differential diagnosis. This is the answer of the first question of the examiner. The second question of the examiner, he will ask you, what are the additional information that you need to know about the patient, or the additional clinical details you need to know? Before answering this question, let's give some information about the vulvodynia. This is a part that will be important for you to understand the background about the topic, either if you are going for part 2 or exam, or to understand it in management of the cases in your clinic. So what's vulvodynia? Again, vulvodynia is a chronic pelvic pain without any identifiable cause. There is the clinical clue here. The vulva, it looks normal in appearance, but there is tenderness on cotton swab testing. So there is tenderness on touch, but there is no obvious reason, and there is normal vulval appearance. Vulvodynia, it may be provoked, which means the pain starts with touch or intercourse or tampon insertion. There is a trigger that will lead to the pelvic pain or vulvodynia. Or it may be spontaneous or unprovoked. Here the pain is constant and not linked to any stimuli. It is classified also into generalized or localized. Generalized means all the genital area, including the buttocks and the inner parts of the side. But localized, it means it may be localized to the vestibule, to the clitoris, or to the labia itself. The prevalence, it is a common condition. It is affecting 15 to 25% of the female at some point in their life. The etiology and pathophysiology, as we mentioned, there is no clear cause, there is no clear mechanism, but it is attributed to certain mechanisms like pain mechanisms. It's considered as a pathological pain syndrome. Sometimes it may be due to maladaptation of the nervous system function. What is the meaning of this? Means the pain will persist after the trigger has resolved. So there was a trigger for the pain, but even after the trigger resolved, still the pain will persist. This is due to maladaptation of the nervous system. The trigger may be a physical event or psychological stress, as we mentioned before. The physical event like touch, intercourse, or tampon insertion, and psychological stress. And this is a very important part to be excluded when you are collecting information. Some terms, neuropathic pain and dysfunctional pain. Neuropathic pain, it results from a structural damage of the nerve itself, but dysfunctional pain means abnormal function of the nervous system. So these are different terms that you should be aware of. Now, the pain in vulvodynia is often described as burning pain, stabbing or shooting pain. It may be due to allodynia. Allodynia means pain that results from normally non-painful stimuli. So simple touch may lead to pain, and the non-painful stimuli will be the trigger here. This is called allodynia or hyperalgesia. There is exaggerated pain response. Yes, there is a trigger. It may be painful stimulus, but the response here is exaggerated. So these are the descriptions of the pain in cases of chronic genital pain or vulvodynia. As we mentioned, vulvodynia has no definitive cause, so it is rarely a single cause, and the treatment is usually combination treatment. So the multifactorial nature, it may be associated with recurrent vulvovaginal candidiasis, and this is a common cause of overlooking the diagnosis because we need to avoid repeated antifungal prescriptions before reaching a diagnosis, or exclusion of a primary pain condition has to be excluded before prescribing treatment for antifungal or antifungal treatment for vulvovaginal candidiasis, which is a commonly reported feature that may trigger chronic pain syndrome. There is inflammatory hypothesis. It was found that inflammation may drive the pain in some patients. This theory suggests that there is a local site-specific inflammatory response, and it was found that the fibroblasts in the vestibule are highly sensitive to pro-inflammatory mediators like interleukin-6 and prostaglandin E2. So now, still we are given some information about the vulvodynia in general before answering the second question. Now, some descriptions of vulvodynia. As we mentioned, based on the location, it may be localized. Localized means vestibulodynia or clitoridynia. It's associated or localized to the vestibule or clitoris. And the generalized, it involves the skin around the inner thigh and the buttocks, or it may be mixed, both of them. Based on the type of the pain, it may be provoked, which is triggered by touch or overactivity, or unprovoked, which is spontaneous, or it may be sometimes provoked and sometimes unprovoked. According to the onset, it is classified into primary, means pain starts from the first sexual activity, or from the first tampon use, or from the first genital examination. So this is primary vulvodynia. Secondary means here the pain begins after a period of pain-free. So the patient was okay, then suddenly she has vulvodynia, like in our case, that the patient was married for 2 years and she just started to have the genital pain since 6 months. Based on the timing, it may be intermittent, it may be persistent, it may be constant, immediate, or delayed. So these are some descriptors of vulvodynia that you should be aware of, especially when you are communicating with your colleagues in the clinical practice. It will make a difference in the final interpretation of the diagnosis. Now, coming to the second question by the examiner. So the first question was, what is the differential diagnosis of the case? The second question, what are the additional information you would like to know about the case? And here we'll start the practical management of genital pain. As we mentioned before, in part 3 or in your clinical practice or in part 2 or whatsoever, when you are discussing the management of the case, you are discussing the diagnosis and the treatment. So management means the diagnosis and the treatment. And the diagnosis means history, examination, and investigation. So when you would like to know additional information, you would like to know additional information from the history, from the examination, and from the investigation. Let's start by the history. When you start collecting the information, you need to ask about the pain features, the onset of the pain, the duration, the severity, and the criteria of the pain. And what are the types of the triggers for this pain? Is it spontaneous pain or provoked pain by intercourse or tampon use or closing or examination? So this is the first part, to analyze the presenting condition. Targeted history means analysis of the presenting complaint and searching for the risk factors or association or complication. So now we analyzed the pain features, and the triggers for the pain. Now, associated conditions. We need to ask if there is any skin conditions like eczema, like lichen sclerosis or planus, or any contact allergy or dermatitis, or any previous topical use, infections like thrush or candidiasis, herpes, or HPV or ulceration, and other chronic pain syndrome. The next point is to ask about the hormonal influences. What is the menopausal status of the lady? If there was any hormonal changes, if she's using any contraceptives or hormonal treatment. Then relevant medical history, including the obstetric and gynae history, including the past pelvic or spinal trauma, because it may lead to pudendal neuralgia or nerve damage. If there is any sphincter dysfunction like bowel or bladder, as we mentioned, Fowler syndrome is one of the associations here. We need to ask about the drug history if the patient is taking any hormonal treatment or diabetic medications. A very important question to ask is about the impact on the quality of life, about the daily activities, about the sexual function and the intimate relation, urinary function, and the effect on the sleep, the mood, and the self-image. Patient perspectives, you have to ask about the patient ideas, concerns, and expectation about her condition, and we can use assessment tools for diagnosis of the genital pain. These assessment tools include a valvular pain assessment questionnaire and the hospital anxiety and depression scale, or the dermatology life quality index. These are assessment tools that will help you in the diagnosis. So these are the information you need to know from the history. From the examination, again, we need to examine the genitalia. Genital examination, we assess the tenderness on genital touch. The careful speculum examination, we use a small speculum if needed. Digital or bimanual examination for pelvic floor organs, and we need to examine other areas apart from the genitalia. Musculoskeletal assessment, inguinal lymph nodes, perineal and perianal skin, to search for other associations. So these are the information that we need to know from the examination. Now the investigation. Let's have a rule or general idea that the diagnosis is usually clinical or mainly clinical, depending on the history and examination. But investigation will be considered only if another cause of genital pain is suspected. And there are red flags that you have to take care of that may need additional investigation. These red flags include persistent ulceration or bleeding, mass or rapidly progressive pain. These red flag signs will need biopsy and urgent specialist referral. Also, if there is any neurological deficit, if the patient is complaining of any numbness or weakness, this will need imaging and specialist referral. So, when you are speaking about the investigation, you will say that the diagnosis is mainly clinical unless there is any other cause of genital pain suspected, like persistent pain, ulceration, bleeding, mass, or if there is any neurological deficit, this will need biopsy, imaging, and specialist referral. Now, when you mention this information or you ask about this information, the examiner will start giving you an additional information. And again, this is the unfair part of part 3, is the examiner attitude. I contacted so many candidates here, so many candidates. Some of them mentioned that the information were not given by the examiner. Some of them mentioned that the examiner were answering their questions about the additional information they need to know. So again, the examiner attitude, this is a subjective evaluation test. It depends on the person who is evaluating you. So don't blame yourself if you feel that things didn't go in the way that you were planning for. But still, this exam is unfair exam, and I will keep saying this all my life. This exam by this system will be unfair, and it depends mainly on subjective evaluation. So the patient here, the information given by the examiner, she is a nulliparous, 30 years old. She's having 6 months history of superficial pain. She's married for 2 years. Initially, she has no pain, but after 1.5 years from marriage, means 6 months ago, the patient started to complain of the pain, which is localized to the vulva and occurs at penetration. She reports no associated skin lesions, ulcers, or abnormal discharge. Previous swabs has been negative. Her menstrual cycles are regular. She has no dysmenorrhea and never used tampons. The recent cervical smear was normal, and she denies any history of domestic or child abuse. The recent cervical smear is normal, means that this patient is tolerating the penetration, so you can exclude vaginismus here. The normal looking examination means, again, there is no structural defect. So our main diagnosis here will be vulvodynia. So the examiner will ask you, after giving you this information, what's your most likely diagnosis? Now your answer will be based on the history and examination finding. The most likely diagnosis here in this case will be provoked vulvodynia. So what will be your management? So there are general principles in the management of vulvodynia. These general principles include: you need to give a diagnosis and explanation and reassurance of the patient, and at the end of the task, we are going to discuss how you are communicating this diagnosis with the patient in a layman language without using medical terms or jargons, because this was one of the questions that were asked by one of the examiner. So provide diagnosis, explanation, and reassurance, offer written information and patient support. Here, the support group is Vulval Pain Society, and reassure the patient that many women improve over time, and combination therapy, as we mentioned, this is a multifactorial condition, so combination therapy often works better, and recognize that there is a strong placebo effect on the vulval pain treatment, and this may support the psychological theory of this pain. So these are the general principles of the management of any case of vulvodynia. Then the second step is the self-care and lifestyle changes. The general advices about the skincare to avoid irritants, to avoid perfumed products, soaps, and tight clothing, to avoid prolonged sitting, excessive cycling, or horse riding, and to use emollient soaps and creams regularly. These are the skincare advices. The second is regarding the sexual health, to avoid any perfumed lubricants during intercourse. So these are the general principles and the lifestyle changes and the advices regarding the self-care in the management in case of vulvodynia. Now the specific management. In the specific management, we are going to describe what is the treatment of provoked vulvodynia and non-provoked vulvodynia. Almost is the same, just a few changes in the sequence of the treatment, or the first and the second line treatment. So in general, again, this has to be multidisciplinary team approach, including the gynecology, dermatology, physiotherapy, psychology, and pain specialist, and the management has to be in genitourinary medicine settings. So these are general recommendations also. Now let's start by the management of provoked vulvodynia. Provoked vulvodynia, it is usually long-standing case. Vulval pain at the introitus, there is a trigger here because it is provoked. The trigger is penetration by sex tampon or speculum, and the pain is often described as tearing and may persist afterwards. The signs: the patient will have tenderness on touch. She will have sometimes vestibular erythema may be present but not specific, and there is no signs of acute inflammation. So these are the clinical features of provoked vulvodynia. The diagnosis, as we mentioned, usually clinical diagnosis based on the history and examination. There is no need for investigation if the swabs are negative, if there is no red flag signs. So the management here or the treatment. The first line in provoked vulvodynia will be to use topical anesthetic creams or ointments. So here we are using topical lidocaine, 5% ointment or 1 to 2% gel. This will be used either daily or only before intercourse. But this local anesthetic may lead to irritation. So during the intercourse, if it's used before intercourse, any oral contact has to be avoided, and the partners are advised to use condom to prevent partner numbness. There are adjuvant approaches here. The specialist physiotherapy for pelvic floor dysfunction is very important. Lifestyle measures like yoga or stretching or self-massage may be another approach, and psychological counseling. Very important point is to have intimacy counseling beyond penetration to reduce the anxiety and shame that results from this pain. The other modalities include pelvic floor biofeedback, the use of vaginal trainers, transcutaneous electric nerve stimulation, injection of botulinum toxin, and cognitive behavioral therapy. Again, very important part. There are alternative regimens here. So you need to try first the first line treatment using the local anesthetic cream or gel. And what are the adjuvant approaches and other modalities? Alternative regimens include the pain modifiers. When we say pain modifiers here, We mean the tricyclic antidepressant like amitriptyline or nortriptyline, the dose will be titrated here from 10 to 75 milligram, and this is a difference between the provoked and unprovoked vulvodynia. So the first pain modifier is tricyclic antidepressant. We can also use anti-epileptic medication like gabapentin and bergabaline, but the problem here in these medications, it has variable benefit and there is possibility of addiction. The surgery. Surgery is indicated, yes, sometimes. Modified vestibulectomy may be indicated in refractory cases of genital pain or vulvodynia, and the best outcome will be in the cases who are responding to the lidocaine. So we may use the lidocaine first as a test. If the patient is responding but the case is refractory, we may advise for surgery or modified vestibulectomy. Definitely, the case will need long-term follow-up support, either psychological and physical support. So this is the treatment of provoked vulvodynia. Now, unprovoked vulvodynia, again, the definition here, it is a chronic vulval pain without any identifiable cause or trigger. So vulvodynia, no identifiable cause. No trigger also means that this is unprovoked vulvodynia and it will be managed as a chronic pain syndrome. Again, the etiology, the cause is unknown and considered as part of the chronic pain condition. The symptoms here, again, it will be long-standing, unexplained vulval pain. It may be associated with urinary symptoms like interstitial cystitis, irritable bowel syndrome, or fibromyalgia. These are association, not causation. The signs, here the vulva appears normal on examination. There is no vestibular erythema as mentioned in the provoked vulvodynia. The complications here, vulvodynia, it leads to sexual dysfunction and psychological morbidity. Diagnosis, again, it is mainly clinical based on history and examination, but we need to exclude other causes of vulval pain before diagnosing the condition. The investigation, there is no need for investigation unless there is another treatable cause suspected, and we may need biopsy, we may need additional imaging if there are red flag signs, as we mentioned, ulceration, bleeding, or persistent pain, or if you are suspecting neurological issues like numbness or tingling. Now, the management, the pain modifiers here will be the first line medication. So in unprovoked vulvodynia, the pain modifier or tricyclic antidepressant will be the first line medication in case of amitriptyline or nortriptyline. Here we are also starting as a dose of 10 milligram, but we gradually increase the dose to 100 milligram depending on the response. So here we are titrating the dose up to 100 milligram. There are other alternative options other than the antidepressants, like other than the amitriptyline and the nortriptyline, like desipramine, imipramine, and duloxetine. Neuropathic agents or anti-epileptic medications that will modify the pain response like gabapentin or bergabaline. Again, if the patient is unresponsive or intolerant to the tricyclic antidepressant, which is the first line treatment, we will monitor here for the addiction risk because, as I mentioned, this medication carries the risk of addiction. There are topical treatments that may be used also in the unprovoked vulvodynia, but not the first line treatment like the provoked one, like local anesthetics, lidocaine cream or gel, and it requires regular application. And as I mentioned before, it may cause irritation and the effectiveness is limited. Other therapies the same: transcutaneous nerve stimulation, cognitive behavioral therapy or psychotherapy, acupuncture, physiotherapy for weak pelvic floor muscles, and botulinum toxin injection. Again, referral, these patients either provoked or unprovoked. If it is persistent, if it is resistant to treatment, it will need referral to the pain clinic or a dedicated vulval dermatology clinic. This is again a very important point that needs to be discussed. What will be the indication and the sites for referral. The follow-up, again, these cases will need long-term follow-up, and the management will be tailored and the follow-up will be tailored according to the patient response. The last question that was mentioned by one of the candidates, that the examiner asked how to explain the condition to the patient. So using simple language, vulvodynia means when you are explaining to the patient. So you will tell her that vulvodynia is ongoing pain in the vulva. The vulva is the area between the clitoris to the perineum, including the labia. There is nothing abnormal to see and no known cause for the pain. Other diagnoses have been rolled out by examination and investigation. It's not an infection, not a contagious condition, and not a cancer. Reassure here that there are treatments that can help to reduce the pain, and most women improve over time with the right support and treatment. This is a way to explain the condition in a layman term, explaining what is the genital area, explaining that it is a diagnosis of exclusion and other diagnoses have been rolled out, explaining it is not an infection, not contagious, and not cancer. Reassure the patient that there are treatments and most women improve with the condition. So in management of vulvodynia, as I mentioned, it is a clinical condition, clinical diagnosis by history and examination. You need to start the management by giving general advice to the patient and advice regarding the self-care and lifestyle changes. Then, according if it is provoked or unprovoked vulvodynia, if it is provoked vulvodynia, it means she will start the treatment by topical local anesthetic like lidocaine gel or ointment, and physiotherapy, psychotherapy, very important here, and adjuvant or any associated treatment. If it is unprovoked, we will start with the pain modifiers, tricyclic antidepressant, the antiepileptics like gabapentin and pregabalin, and you will mention also the topical treatment and other alternative therapies in this case, and you will advise about the long-term follow-up. So this is the case. I don't have full information about this case, but if they are going to evaluate you in the information gathering, they will need you to be targeted when you are collecting the information about the patient. You need to ask about relevant history, including the pain criteria, what are the triggers, and what could be the associated conditions. If it is vulvodynia, I can consider this as a failure point if you did not collect a good information about the patient. You need to explore the impact on the quality of life. You need to ask about the mood, any association with any sexual dysfunction, and the effect on the intimate relationship. A very important question to ask about the screening for sexual abuse and the psychological factors. These points can be borderline points. You need to explore the red flag signs. If there is, during examination, if there is any ulceration, masses, or bleeding that may warrant biopsy or additional investigation. You need also to explain the diagnosis to the patient in a clear and simple language and give a realistic reassurance. This will be the part to answer the question of the examiner, how you are going to explain the condition to the patient. Very important to provide the patient with patient information leaflet and support groups. This will be the points that you need to cover in the information gathering. In the communication here, it is a communication with colleagues. You need to be a leader in the discussion with minimal prompting. The way to start this type of discussion, it will be by what's your differential diagnosis, or what are the additional information you need to know. Actually, what are the additional information you need to know? If this is the first question, this will be an open question. So you can start by saying, based or putting the most suitable differential diagnosis in mind, and explain the differential diagnosis. And then the second step, based on this differential diagnosis, I need to ask the next information from the history examination and investigation, and you will be considered as a competent candidate leading the discussion with minimal prompting. The second point in the communication is to demonstrate the ability to formulate a proper management plan, and to describe a clear and logical approach to the problem, and to respond positively to the questions of the examiner, and to speak an appropriate technical language. And the last point in the communication with colleagues will be explaining that the communication with colleagues this condition has to be in a multidisciplinary team, including the gynae dermatology, and you need to explain the gum clinic, the pain clinic, and the psychotherapy or the mental specialist. This is a part of the communication with the colleagues. Now, coming to the patient safety, you need to avoid unnecessary or harmful treatments like the repeated antifungal. You need to recognize the red flag signs. You need to require urgent referral to the pain clinic or vulval dermatology clinic. You need to recognize when the patient will need referral. You need to recognize what are the indications of biopsy or the indication of additional investigations, and you need to explain that this is a diagnosis of exclusion. So these are the possible points in the patient safety here. Now, in the clinical knowledge, Definitely, the first important point is to be able to give a proper differential diagnosis of chronic genital pain. This will be considered as a failure point if you are giving enough data. If you are not giving enough data, you need to identify what's vulvodynia. And you need to mention that the most likely diagnosis here is vulvodynia, given the normal examination findings, the negative history and the negative swabs as mentioned in the GB letter or will be given by the examiner. You need to mention the evidence-based treatment plan. What is the general advice? The lifestyle changes. The first line treatment, which could be the tricyclic antidepressant if it is unprovoked, or the local anesthetic if it's provoked vulvodynia. The second line treatment, the alternative and the adjuvant treatment, and what could be the indications of surgery. So these are the points that need to be mentioned here in this task. How to cover the task from all the points here. As we mentioned, we cover the task here from the part 3 point of view, from the part 2 point of view, and the most important, in my opinion, and this will remain with you for your life, is how to use it in your clinical practice or the practical management of cases of chronic genital pain. This is a part that will remain for you. It's not only about the exam, it's about how to give benefit to your patient by understanding their complaint. So I hope that this topic now is clear for everyone from the exam and from the clinical point of view. If you find it useful, please remember me and my family in your prayers. Thank you so much. See you inshallah in another session and another topic. Wassalamu alaikum wa rahmatullahi wa barakatuh.